Hi, this is Jessica Leone from Primary Care Research Institute. I'm going to be hosting a webinar called the New York State Cancer Report in Response of Community Organizations, and this is funded by Erie County Department of Health. So what is the purpose of this webinar today? Our community has greater concerns about cancer rates within the east side of Buffalo and West Cheektowaga. We're going to highlight the New York State Cancer Report, and also we're going to give some tools to facilitate self-advocacy within a medical setting. Today we still see gaps between race and ethnicity when it comes to different health illnesses and diseases. For example, I pulled these charts from the Center for Disease Control. The graphs show new prostate cancer cases in the United States in 2016 on the left, and on the right the graph shows new cases specifically for Erie County. We can see in both graphs that African Americans have a higher rate of prostate cancer than any other race. And when I say rate, I mean the number of cases per 100,000 people. As this is just an example, this gap is affluent in other health outcomes as well. And I think it's just important to acknowledge that this gap still exists and is present within our community itself. So multiple factors contribute to African American health disparities. For example, we can think about the social environments such as educational opportunities or ethnic or racial discrimination. We can think about work conditions or neighborhood conditions. And lastly, we can think about access to preventative health care services such as cancer screening. So more specifically to Erie County, the New York State Department of Health pulled data from 2011 to 2015 to determine if there are high rates of cancer within specifically the east side of Buffalo and West Cheektowaga area. In this area, our community mostly serves African Americans. 70% of the population is African American, and we can compare this to Erie County itself, where 78% are in the white race alone. We can also see from this graphic that 33% of the population live below the poverty line, which is around $12,000 for an individual and $24,000 for a family of four. This is just an interesting piece of data and really shows the population that we should be targeting our efforts to. So, as for the New York State study itself, the New York State Health Department launched the study in 2018 and released the report in October 2019. This is the study area shown here. Walden Ave is the border along the bottom, the 90 borders the right side, and the 33 borders the top and left side of the area. The health department launched the study to examine trends and risk factors in the different regions that had higher rates of cancer. Erie County is one of them, along with 3 other sites. So what did they look at? They gathered information from secondary sources like the state's cancer registry to pull socioeconomic data, cancer data, behavioral, healthcare, and occupational data. And lastly, they pulled environmental data to determine patterns and trends and contributing factors to the higher rates of cancer in this specific area. From these resources, they looked at different risk factors such as tobacco use, obesity, healthcare coverage and services, outdoor air pollution, radon, drinking water, industrial and hazardous waste, access to healthy foods, traffic patterns, and lastly, occupational exposures. But it's just important to touch on that New York State did not come into this area itself. They just used these secondary sources to really determine the risk factors and trends. So they didn't come in and look how many grocery stores were in this area, or they didn't do soil sampling. So that's just an important thing to acknowledge when thinking about this study itself. So what cancers did they find? So according to the New York State Cancer Report, oral, lung, esophageal, prostate, kidney, and colorectal cancers were all higher within the east side and West Cheektowaga area. So I'm going to go through each cancer and just talk about what they found and different screening recommendations for each. So to start off with oral cancer, This includes cancer of the mouth, including your lips and salivary glands. New York State found elevated levels of oral cancer, but there's no recommended screening, and symptoms are not always obvious. We can usually look for sores, lumps, or thickening of lips, gums, or mouth. HPV is also another risk factor for oral cancer, and New York State concluded smoking and alcohol consumption might have been attributing factors for the rise in oral cancer. Next is lung cancer, and this was the second most common cancer found in the East Side and West Cheektowaga area, and was mostly found in men ages 65 and older, and was also higher in African American men. Smoking attributes to a large number of lung cancer cases, as well as radon, and radon is usually found in basements. The recommended screening for lung cancer is a low-dose CT scan, but individuals who have a current or past smoking history of 15 years are eligible. Next is prostate cancer, which only affects men. Prostate cancer was the third most common cancer found in this area. African American men have the highest risk out of all of the races for developing prostate cancer, and we saw that in the first slide that was presented from the CDC. A family history of prostate cancer can increase your risk of developing the disease, and it's so important to find out if anyone in your family has prostate cancer so you can start screening early. Screening for prostate cancer is a little bit confusing, so they can test your prostate-specific antigen, or your PSA, through a blood test, and then they weigh the risks and the benefits of the screening based on the individual. So usually prostate screening starts at 55 to 65, but men older than 70 should not be screened. Next up is esophageal cancer, and it's located within your neck, and it's relatively rare. The risk factors for esophageal cancer include obesity, alcohol, or tobacco use, and there's no recommended screening for this cancer. Second to last is kidney cancer, and it's located within your kidneys, which produce urine and filter your blood. This was the only cancer in the New York State report that was higher in both men and women. Risk factors for kidney cancer could be family history, hypertension, obesity, smoking, or alcohol use. Symptoms for kidney cancer include blood in your urine, pain that does not go away, or lumps in the side. And it's really important to tune into these symptoms because there is no recommended screening for kidney cancer. And it was greater than expected in African American men from 50 to 64. Lastly is colorectal cancer. Screening for colorectal cancer begins at age 50 until 75. And you usually get a colonoscopy every 10 years, but there's also other screening tests called the fecal immunochemical test, or a FIT kit. Family history and genetics can be a risk factor for colorectal cancer, and individuals who have a parent or sibling with colorectal cancer are at a higher risk. So just to recap, oral, esophageal, kidney cancer all do not have recommended screening. Lung, prostate, colorectal do. So with that, thinking about screening, we can think about patient barriers to screening, such as inadequate access to healthcare or availability of services, competition of priorities, lack of knowledge or awareness of preventative methods, cultural sensitive cancer prevention approaches, mistrust of medical providers, which I think is a big one, and the fear concerning treatment. For example, we can think of a colonoscopy, and a lot of people might fear the prep for this or even fear the procedure itself. As for risk factors, we can think about it as a whole, so behavioral, environmental, and individual itself. So within the New York State Cancer Report, they thought a lot of the behavioral risk factors contributed to the rise in cancer rates in the East Side and West Cheektowaga area. But we can also think about the individual. So many of the 6 cancers have risk factors relating to family history, and knowing your family history is a free personalized tool to help you with disease prevention. I think that many people underutilize the idea of relatives history, especially health professionals. Family history helps advise patients on screening and health outcomes while also promoting their own self advocacy. So, next, I'm going to do a little skit. We have a good version and a bad version. I'll do the bad one first, and then I'll discuss a little bit about the differences after. So, it starts with the patient. Here we go. Dr. Jones, I'm here today because I've been losing weight. Losing weight is a good thing. You have hypertension and cholesterol, and your cholesterol is a little elevated. It seems my stomach has been very queasy, and I am nauseous a lot to where I don't have an appetite. Well, try to eat some crackers or some toast and see how you feel. Don't you think I may need some lab work or some kind of test to see if I have something going on? Just try this first and come back in 2 weeks, and I will give you some medication for the nausea. Let's try to get your colonoscopy scheduled. You are due. Okay, I will try it, even though I do feel like something else is going on. Okay, I have another patient I have to see, and I will see you soon. So that was the bad version. And here is the good version, starting with the doctor. Good morning, Mrs. Ragland. How are you doing? Is there anything you'd like to address today? Dr. Jones, my stomach is really queasy and has been for over a month now. I have no appetite as well as I've been losing weight. Mrs. Ragland, even though losing weight is a plus in a lot of situations, this is not normal for you. We will get some blood work ordered before you leave. Have you eaten today? I have been really nauseated, so I have not been eating. Has something happened recently to bring this on? Well, Dr. Jones, my son in Michigan has recently been diagnosed with lung cancer, and I'm so concerned about him. I'm so sorry to hear that about your son. That must have been very stressful. Do you have anyone you can talk to about this, such as a pastor or counselor? Thank you. I do attend church regularly and find guidance through praying and talking with my pastor. That's great. Continue to use your social supports when you need help and let me know if you need any referrals to anyone else. I see from your past history that you've had an H. pyloric from a nervous stomach from some years back. Let's get this lab work done and go from there. I'm not going to prescribe anything today, but I would like to monitor your appetite and journal the foods that you eat when you get nauseous. Have some crackers and ginger ale in the morning or some hot cereal in small amounts. No fried foods till you return. Thank you, Dr. Jones. Lastly, since cancer runs in your family, I would like to get some blood work for this. You are due for your colonoscopy. Let's get this scheduled. I agree. Since my son has been diagnosed with cancer, I feel I should be proactive about screening. I hope your son is doing well, and we'll figure out what is going on with your weight after we get the blood work back. Let's focus on you. Is there anything else you would like to address today? No, thank you, doctor. I will see you soon. So I just want to highlight some important points from both skits. So when you think about the first skit, the doctor didn't really show any sympathy for that patient and kind of rushed the appointment, which I'm sure many of us have felt before. And for the second skit, the patient spoke up and didn't hide what was really going on. So she talked about her son's lung cancer for a reason why she might be nauseous or not eating. The patient was more likely to be positive about screening because her doctor connected with her in the first half of the skit. And she was also had the ability to address her concerns about her health. And that's really important because we can think about patient self-advocacy. So when I say patient self-advocacy, I mean making your voice be heard within a healthcare setting, allowing the patient to be actively participating in their own care by deciding what they need, developing a plan, and carrying out the plan. More specifically, patient self-advocacy is when individuals demonstrate an increased willingness to challenge providers and to actively participate in decision-making. But there are some barriers to self-advocacy or patient advocacy, including fear, lack of knowledge, or confidence in the situation itself. Patient knowledge, experience, and concerns are all just important as a provider's view. And we want to focus on supporting and giving the tools to patients to make decisions within their own healthcare. And communication is so crucial to this piece within the healthcare setting. As for health literacy, I think self-advocacy directly links to health literacy by supporting the idea of information gathering or active participation. So the CDC defines health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make appropriate health decisions. So it's really just simplifying information, using plain language. And then as for culture, I think culture is an important topic in health literacy because culture really affects how people communicate and understand and respond to their environment and to health information specifically. So health literacy definitely plays a role in cancer when it comes to diagnosis, treatment options, and staging. So I really like this slide just to show why health literacy is important and how it connects to understanding something simple as nutrition, which really is not as simple as we all think it is, or completing paperwork within that health care appointment, seeking support, where do we go, who do we call, and really understanding medical instruction. So what do we need to do? Why do we need to do this? Why are we taking this medication? And maybe you could think about how your community organization can apply a level of health literacy for your community members. So this could just be having that easy and clear and concise language on flyers and brochures, or making sure those brochures are easy to read. Also maybe using those health cues within your bingo or daily activities, something like that. But really think about how you can build your health literacy of your community members within that community setting. But building health literacy skills will help facilitate more effective patient engagement, which is pretty much the ultimate goal. Ask Me 3 is a really good source that we could use just to sum up appointment within the medical care setting. So it's used after the doctor goes through all their information, and the patient can ask these three questions just to sum up that appointment and what they actually need to do in the upcoming months. So what is my problem? Starting with that. What do I need to do, and why is this important for me to do this? So just prioritizing, finding that common ground between the provider and patient, and just having that really good patient-provider interaction to sum up the appointment. So we created this appointment planning worksheet. If you're interested, my contact information will be at the end of this presentation. You can reach out to me if you want some copies of this. So it's just a brochure to say, how can I talk to my doctor about cancer prevention? So in the middle, we provided some services. Erie County Cancer Service Program provides free screening of mammograms and colorectal exams, and the website's on there and the phone number's on there as well. We have some transportation services because we know transportation can be a barrier in many situations. And then 211 Western New York is a great 24-hour hotline where you can find all sorts of information. And then on the left, we have things to bring to your appointment just as kind of like a checklist. Next, I'll go through the inside of this brochure. So on the left-hand side, we have cancer risk factors, focusing more so on family history, which I touched on in the beginning of this presentation, just stressing the importance of that. And on the bottom, the individual can write their own risk factors in that box. In the middle, just going through the regular screening guidelines, colorectal cancer, age 50 and up, just age 75. And then we have screenings for patients at high risk. So if you had a family history of kidney cancer, you might get a CT scan, or patients with Barrett's esophagus might have a regular endoscopy recommended for esophageal cancer. And then before your visit, maybe fill out some specific questions or concerns you have to guide your interaction with your provider. And then to the right, filling out your cancer screening plan. So just going through and doing last date screen, next screening date, just to have that somewhere easy to grab. And then lastly, the Ask Me 3 questions we incorporated in this brochure. So ending your appointment before you leave, make sure you understand these questions. So just some key takeaways, our key messages. So we really want to encourage community members to go to the primary care doctor first and foremost. We want to support community members by being their own health advocates, by facilitating the process of information seeking, looking for information in brochures or online to be knowledgeable about either their health problems or their family members as well. Allowing an open and accepting space for conversations about cancer in a community setting, and really encouraging individuals to ask those questions to the provider, to family members. And then I have a little note, so it says self-advocacy. Know yourself, know what you need, and know how to get it. And lastly, here is some contact information. I am Jessica Leone, and I am the one who's presenting, and my email, so feel free to email any questions or comments, concerns to me. If you want any of the materials, let me know. I can send those to you as well. So thanks for tuning in. Bye.